Welcome back, guys. This week on the channel, we are joined with Dr. Jamie Mraz, and we are discussing the most common injuries we see in the tactical setting, but more importantly, what you can do to prevent these injuries from happening. Jamie, appreciate you being on here with us. Before we dive into the main subject tonight, why don't you tell everybody a little bit about yourself?
Yeah, thanks for having me on. So my name's Jamie. For those of you that I haven't interacted with, you may know me on Instagram as Doc Mraz, but I'm a physical therapist. I've been practicing for about 15 years. Over 11 of those years have been spent working for the military. I'm also a military spouse. We are currently stationed at JBLM out in Washington. So look forward to diving into this topic today.
Cool, yeah, absolutely. So a lot of experience there, a lot of knowledge brought to the channel this week from Jamie, Dr. Mraz. So let's go ahead and dive in. So we look at the tactical setting, we see injuries all the time. So in your experience, what were some of the most common ones you saw frequently from soldiers?
So if we're looking at the military, and obviously there's different MOSs, different job demands, so some things will vary a little bit. But pretty much across the board, we're seeing low back pain that we're going to say, let's call it mechanical overload. And by overuse injuries, we're saying there's no mechanism of injury. So it's not, blowing out your ACL or blowing out your shoulder. These kind of just build up over time injuries. So across the board, low back pain. I've primarily worked with infantry in my time. So for infantry soldiers, we're then going to see a lot of anterior knee pain, otherwise known as runner's knee or patellofemoral pain. And then I'm going to lump just a ton of diagnoses together in like lower leg foot issues. So that could be shin splints, posterior tib tendinopathy, plantar fasciitis symptoms. So yeah, for infantry, we're looking at low back pain, anterior knee pain, and then the umbrella diagnosis of lower leg injuries. Where things start to vary a little bit, if we look at like artillery, for example, they're doing a little more heavy lifting. So I tend to see less of the lower leg injuries with them and then more upper body injuries. So shoulder, upper back, neck.
Cool. Yeah. So that's a lot of what I've seen too. We look at that, just a lot of lower body injuries. We do see some upper body injuries, people just not warming up properly and then just trying to get under a load. But would you say these low backs, these knees, ankles you see, do you think that's more of people not doing the right things throughout their career, like warm-ups, prehab, whatever else, or do you think it's along the lines of just the demands of the job? Obviously, getting under a heavy ruck, running with it, like that is going to put wear and tear on the body.
Yeah, I mean, obviously with the military, I think any tactical professional, there are job demands that are very unnatural to what we do as humans and what the rest of the population does, such as all the, PPE, the load-bearing gear, all those things. But I think most overuse injuries, and this is probably the same in athletics, are going to boil down to one of three things. They're either asking their body to do more than it's currently capable of doing, which is a general fitness component or a preparedness conditioning component, or they're doing too much too soon, so significant fluctuations in volume. And this is particularly common in the military where they'll be gone for training and they're basically not, and by training, we're saying like tactical training, not fitness training. So they'll be out of the fitness for a few weeks, come back, they want to hit the ground running, significant ramp up of running, lifting. Their body has already detrained at that point. So we'll get the overuse injuries from then just ramping up too much too soon. And then the third one is, I call it doing too much for too long without adequate recovery. And this is really variable on the person. Some people are able to tolerate this for longer. They're either able to tolerate more or able to tolerate whatever for longer periods of time. And I think that's based on just their overall health. So their nutrition, their sleep, do they drink, do they use tobacco, nicotine? All those things play into the how much can you tolerate before something breaks.
Yeah, there's a lot of good stuff there. And it sounds simple, but you see it so often, like a lot of the things you just said there. Like how many times have you had units come to you saying, or going to the coaches you work with, hey, we have a 12-mile ruck in 3 weeks. What should we do? And you're like, you should have started a while ago.
Start a while ago.
And then sadly, the worst part is you get a lot of individuals, and Jimmy has said it before on here, you don't know what you don't know. And there's a lot of education that's missing in this setting, but you'll get people trying to prep for a 12-mile ruck with no work in a month period, into where, unfortunately, a lot of people think like, oh, well, we just have to ramp it up. We have to do more. You're trying to shove more work into such a short window. And obviously we see that those spikes in injuries. And then we've talked about it before on here. Typically when we're preparing for any sort of event, or even just in our training, we're not going to increase more than 10% volume per week. But if I say, hey, like these guys have to go do a 12-mile ruck in 4 weeks, or if a soldier comes up saying, hey, my guy's doing a 12-mile ruck in 4 weeks, and they try to go from 4 miles this week to 8 miles, a 50% jump, like we are asking for injuries. And I'm sure you've seen those all the time. And it's it's tough to try to get people to understand of like, hey, while progress may be slow and it may seem slow, we are truly better off long-term continuing to follow that 10% rule and not trying to jump or make up for lost time.
Yeah, and I think the Army is particularly bad about being reactive versus proactive about everything. But with the H2F, they staffed the units with a huge staff of strength and conditioning teams, and then a huge staff of healthcare professionals. And at least what I've heard from a lot of colleagues is the healthcare professionals continue to get overrun, while the strength and conditioning professionals are not always being utilized as much as they could. And by doing that, we're really leaving a lot on the table for the preventative aspect as far as preventing these overuse injuries.
Yeah, so you have to be proactive with it. And like you said, unfortunately, a lot of times we see is the military ends up being very reactive.
Yeah, fix them when they're broken kind of a thing.
Yeah, and I get it from like, and I'm guilty of it to some degree, like when I look at my own training, because like I'm always going to push myself harder, like, oh, like I can do it. And like as I've matured in my training, like I can look back now and be like, ooh, that was so bad. I just kept trying to push it there. And I'm still guilty of it sometimes, of trying to do a little bit too much. Yeah, I had it, and I talked to Andy about it one time on here, where I was doing intervals, and I looked to one of the other coaches like, dude, I'm going to send it on the last one. And he was like, that's stupid. I'm like, you're right. Thank you for putting me in check here. So we all need that from time to time. The other thing, though, I really like that you talked in there is talking about coming from, or we see injuries coming off a hiatus, whether that's block leave, whether that's training in the field. So unfortunately, we see a lot of individuals who, maybe, like I said, block leave in the field, they come back, they're untrained, but they try to pick up exactly where they left off. And that leads to an injury because their body is not ready for that stimulus that they're putting on themselves at that point. So we need to make sure that we're coming off a training hiatus, that we do it the right way coming back. So like scale it back a little bit and then continue to work that 10% increase in volume per week. So Jamie, let's talk about, let's look at a specific injury and something you might give soldiers or, other members in the tactical setting of, hey, this is starting to bother me.
Okay.
Like, what are some things we can do at that point? Because we're all going to get to the point where like we don't feel 100%. Anyone who's training consistently is not always feeling 100%. But let's look at some things to not derail our training, or things we can do to not derail our training.
Okay.
So whatever injury you want to look at, let's just kind of do a little case study right here.
Okay. Let's do either low back or anterior knee. Which one you want to do?
Oh, those are both such good ones. Selfishly, I'm going to say anterior knee because I grew up with odds of slaughter in both. And if I do poorly with my ankle and hip mobility, I will definitely still feel it.
Okay. So anterior knee pain, basically something on the underneath part of the kneecap has been irritated. That can be cartilage. It can be the fat pads. We'll go ahead and lump patellar tendon into that as well. It's kind of a separate anterior knee pain diagnosis, but let's just lump it all together. Usually that's going to get overloaded from high impact. So a lot of running, rucking, jumping. Honestly, it's one of the, I think, most difficult injuries to rehab in the tactical setting. When I worked in athletics, it was much, much easier. But for the military athletes, even outside of their morning fitness, everything they do, like the crawling, kneeling at a range, it all kind of loads the knee. And so it's difficult to get the symptoms under control a lot of times. How I approach it in the clinic, it very much depends on the person. So I have a general framework of like anatomically what we want to do, but then as we had already talked about, any overload type mechanism, we have to consider like what's going on with that person. So what is their general fitness? Are they new to the Army? They're struggling with their run time. They're struggling with their BMI. That is a whole slew of issues that tells me this is going to take a lot longer versus the healthy soldier that's got good muscle tones, pretty strong, a good runner, and they truly did just kind of overload things. So I think we have to look at all of that as well. But so let's go with they've kind of got everything else dialed in person, and we're just going to go like rehab wise what they need for the knee. So usually there's going to be a period of deloading from impact. And then we're going to supplement that with basically whatever low impact cardio they enjoy and they can tolerate. So that might be the assault bike, it might be a rower, it might be incline walking on the treadmill. I, in theory, would love to send people to swim, but the pools are not readily accessible. Versa climbers can be great, but basically we want to find some mode of cardio that they can tolerate without significantly worsening their knee pain. And then we're usually, it's kind of same concept as running. We want to do some interval days, and then we want to do more of the zone 2 endurance days. And usually I'm just coordinating with a strength coach of like, hey, let's pull them off of running, but they're good for whatever low impact, you want to do with them. And then we have to look at like the strength component of it. We know clinically that poor quad strength correlates with anterior knee pain. Whether the poor quad strength caused the anterior knee pain or vice versa, we don't know. We just know that they go hand in hand. So we need to typically increase the robustness of the quad. Unfortunately, those are usually the movements that also piss off the knee pain. So typically we start with like open chain quad stuff. So think like leg extensions, and then mid-range closed chain stuff. So that's going to be like maybe a wall sit and like 60-degree knee bend or like a split squat iso. But for a lot of people, they're going to have that anterior knee pain either locking the knee out all the way straight or as they approach like 90 degrees. So if we can kind of work in like a mid-range, we can typically start doing some quad loading.
But now with that, are you starting them with isos or eccentrics, or how are you doing that?
It depends on what they can tolerate. So isos, pretty much everyone can tolerate. There's even pretty good evidence that, isos are pain modulating and can actually relieve some of the pain. So I think most everyone can start with isos. Usually I'm prescribing them frequently because if you're doing like a partial range wall sit, it's not super hard, right? Like you could do reps like throughout the day just to kind of accumulate that load. Once they're tolerating like isometrics pretty frequently, pain has kind of gone down. Then I'm probably going to bump into more eccentrics, but it still may be in a limited range. And it kind of just depends on what's bothering them. So if they can't approach 90, we're just going to work above that. If they can't lock the knee out without pain, we'll kind of keep it in like a modified range. All the while, we're still training around pain, so they can usually still do posterior chain work, hip hinging movements, hip stability drills, calf work. They should be able to do all of that. They should be able to maintain their core work, maintain their upper body work. From a physical therapy perspective, a big piece of my job is just modifying their training program and giving like you guys guidance on their right and left parameters. And then sometimes we're then coming in giving people a few extra rehab things. For the overload diagnoses, I'm hesitant to give people massive rehab programs that they have to do then on top of their daily fitness, because if we're kind of already saying they're overloaded, I don't want to just give them a ton more shit that's unnecessary volume. If we can just kind of modify their training program, add in a few necessary things, and then build up from there.
Yeah, so you talk about adding in those necessary things, and every case is going to be different. But about how many times per week are they doing these necessary things that you're adding in? Is it twice, 3 times, daily, or again, like I know it could differ by case.
It depends. If it's some kind of range of motion work, like let's say they have a joint restriction, that to me is something that needs to be done daily, multiple times a day. If we're doing the early phase isometrics, those need to be done multiple times a day. Let's say they have a hip, like a lateral hip weakness that's a deficit. That to me is like we're looking at hypertrophy. So we're going to want to load that up 2 to 3 times a week. That should not be a daily thing. If it's done daily, you haven't loaded it enough.
Cool. Yeah, absolutely. So one of the things that, especially as I've gotten older, that has become extremely frustrating, and I know some of the viewers are going to have dealt with this as well. You have one nagging pain. You have one nagging pain. You start working on that, but you're still doing your training. You're training smarter. And then the next nagging pain comes from the body overcompensating. So what are you telling clients at that point? Like, are we then like shifting our focus? Are we now adding multiple things to some of that work that we're doing? Like, how do you go about that? If that makes sense.
Well, so I think a good like rehab anyways should kind of take into account the whole body. Like let's call it knee pain. A good knee exam should have also included an ankle screen, a hip screen, a low back screen. If there were any, blaring massive red flags, they should have been picked up on exam, and then we should be doing supplemental work to address those things. But let's say we missed all of that. It is possible that just things have come up compensatory. It's also possible, I think, for some people, once they kind of get engaged with rehab, they get a little more in tune with their body, and maybe they're paying attention to things a little bit more. They're kind of starting to try to like put those puzzle pieces together of like movement compensations, like why did I get hurt? And maybe they're just starting to pick up on some things that they normally were not really aware of. I see that a lot as well.
Yeah, absolutely. It made me think of it because we used the knee example. You were talking about the anterior knee hurting. I had it about 6 weeks ago, maybe 8. I don't know. Where I started to get a little anterior knee, just irritation. I didn't think it was anything. It was just irritation. It was like right under the kneecaps. All I did was do some movements to take some load off, like to take some of the anterior loaded movements off. And then 3 weeks later, I was having hamstring tendinopathy. So I've been dealing with that now. It's gotten better, but I've been dealing with that probably 3-4 weeks or so. But I've been absolutely crushing my isos and heavy eccentrics with it. And so you talked about the low impact cardio. Took 2 straight weeks off of any sort of running. Did all my cardio on the bike. Had it feeling much better. Some of the physical therapists that I talked to had to remind me to do exactly as they said. Because again, like I said earlier, I'm a competitive individual. It's like, hey, it's feeling better. Let's try it. So I remember, like I was saying before we got on here about one of my friends, she's a physical therapist. And I remember she gave me some exercises. Like 2 days later, I was feeling better. And I messaged was like, how do you feel about me doing a run tomorrow? And all I get back is I get one message.
No
follow up. That was, I suggest you do what I said for week 1. I was like, got it. Perfect. I was like, no run, not doing it. So yeah, if you're like me and you want to continue to push it, listen to the professionals that are telling you to ease off. It's not going to hurt your training. It's truly actually going to better your training if you take that step back and fully recover, as opposed to thinking of, hey, I have to push through the pain or pain's not always just mental. Like there's definitely those times where you have to listen to your body. There's definitely those times where it is mental. Like I know, you talked about like being a little bit more aware of your body. So now as I've introduced running back into it, I feel like I am hyper aware of exactly how my hamstrings are feeling in my left knee. And then I'll probably kind of overlook some things like, ooh, that movement didn't feel great. But then it's just me concentrated on it. So make sure you're listening to those professionals, because whether you take 2 weeks off from running, or if you're taking 2 weeks off from running, it's going to help you so much more long term in your training, as opposed to you trying to push through 2 more weeks of running and now you're further setting yourself back. Jimmy said it last week on the channel when we talked about warm-ups. You're warming up to not get hurt. And as a strength coach, or one of the reasons you're warming up is to not get hurt, and that really should be the main reason. But as a strength coach, I've always said my number one goal when somebody's in a training session with me is for me not to injure them, because that is the absolute worst thing I can do, because now they can't train. Now they're further away from their overall goal.
Agreed. I do want to caveat one thing. So, and since you talked about your knee pain, I have to talk about mine too. But the main point of what I want to go down is make sure if you're, whatever kind of musculoskeletal injury you have, the provider should still always give you an option for exercise. It may be to modify, like it may be to bike instead of run, or to do a box squat instead of a depth squat. But you should never be given guidance for don't exercise. And I say this because, so I've been having knee pain since like March-ish. And I ended up going to, like, all my like physical therapy tricks haven't really helped. So I went to see ortho, and this was on base, so active duty ortho. Hopefully he's not listening, but maybe if he is, he'll learn something. And to get a cortisone shot. And he looked at my MRI, and basically I just have like osteoarthritis, so presumably a arthritis flare up. And he was like, at your age, I know how like you active people are. And I'm like, are we stereotyping now? But he's like, you active like people, but like at your age, you really need to like stop all the running and the lifting weights. And this is, mind you, like a colleague that I have collaborated with. Like he's seeing active duty soldiers, and his best advice is to stop running and stop lifting weights. And I'm like, with all due respect, you should know that the research doesn't support that. I know that. You should be advocating for people to still stay active with arthritis and with whatever musculoskeletal injury. So if you go to the doctor and they tell you to just stop doing shit, you need to find a different doctor.
No, yeah, absolutely. I've always said that. And I've definitely worked with healthcare providers before that have said, oh, just don't do anything.
Yeah.
And that doesn't
help.
Especially if you're going to tell an active competitive individual, like, don't do anything, like you're just mistreating them, because that's not going to work. Like, let me know how to do the movement safely. And you can always find, like, and again, like, there's a lot of things people just don't know, and it's perfectly fine. But like how simple of modifications you can make during your training sessions to do a movement comfortably can be as simple as, if there's a step up programmed, maybe you lower the height of that step up. Maybe you start with a 45-pound bumper plate. If you're able to do that too easy and it's just extremely comfortable, maybe you add a 25-pound bumper plate, and maybe that is the right height for you. But we're still getting so much more out of us doing a shorter step up, as opposed to doing nothing, or just going and walking around the footprint, which you sadly see all the time.
Yes.
So,
well, and not to mention just the mental component of that, of like to feel like you can't do anything is like fucking depressing. Sorry, I don't know if we can say bad words on here, but it's depressing.
You can say fuck, it's fine.
Okay. I mean, I think people need that. Like, they need to still be able to train, especially, our population of like us and who we're working with. Like, if you're so hurt that you can't move, you gain weight, you get pulled out of your peer group because now you're not exercising with your friends every day. Your unit starts to think poorly of you. And then a lot of bad things happen mentally, and they don't need to.
Yeah. And I think that's such an overlooked thing. Like you said, the mental aspect of it, because you're not with your peers. I've seen it countless times before. People are like, oh, they must be over there just shamming. whether they are or they're not. Like, there definitely are some people who are shaming over there.
Sure.
But yeah,
I mean, that's life, though. Like, those people always exist.
Like, not even just in the tactical setting. I'm sure you've seen it before. Some of the worst spots I've seen people mentally in athletics was after an injury, because, like you said, they're now taken away from their peers. There was a guy I working in football that he tore his ACL last game of the year. He was looking to get drafted. Okay, well, now he's back for another year. He was a redshirt junior. So a lot of the guys he came in with were seniors who just graduated. And now he's back dealing with an ACL injury. And, like, I'm sure you've seen plenty of people dealing with an ACL. Like, it puts you into a bad spot. Like, you're not able to be yourself. Like, you're removed. Like, it's not easy.
Well, it's isolating, and it doesn't have to be. I mean, it's going to happen to some extent, but it doesn't happen to, I don't think, the degree that sometimes the medical system encourages.
Yeah. So, absolutely. If you are struggling with an injury and you are in that spot, you can definitely work yourself out of it. You're not alone in thinking that it's just you. Like, a lot of people have been in a bad spot coming back from an injury. So just continue to work, find ways to get out there and train. Put yourself around people. Do not isolate yourself in that situation. So, Jamie, is there anything else you want to touch on as far as injuries in the tactical setting?
No, I mean, I'm open to talk about anything, if there's any other questions you have or whatever you think.
Cool. So you guys let us know in the comments what injuries you've been struggling with throughout your career, or if you have any modifications or any questions on modifications for exercises as you deal with some of these injuries. Make sure to drop those into the comments for us. Jamie, before we go, let's talk a little bit about what you're bringing to Modern Athlete. You've been working with the team. You've been working with the team now for, what, a couple years?
Yeah.
But now you're finally getting your own team. So why don't you describe a little bit about what that team is that you're bringing to Modern Athlete and how to best pair that with your other training programs?
Yeah, so I've been a commitment phobe for years. So I've been putting this off, and now it finally feels like a good time. So what we're doing is it's called Warfighter Mobility. We're using the word mobility because it's just kind of what most people understand the easiest. But when most people think of mobility, they think of like stretching, and that's not what we're going for. Mobility in and of itself doesn't like reduce injuries or anything, as long as you have enough range of motion to do what you need to do. But what we're going to use mobility for is to improve body control, improve joint control, and then we're really going to work on using movements to like improve joint health. So the cartilage inside your joint doesn't have its own blood supply. So the only way it can like get nutrients in and flush like waste product and inflammation out is through movement. And when we do, like, let's look at the hip. If you're, at the gym crushing your leg day, you're going to do your hinges, you're going to do your squats, you're going to do your lunges, which are all kind of moving things in like a linear flexion extension pattern. So we want to incorporate a lot more rotational work and then some lateral work to really hit kind of all surfaces of that joint cartilage. So what we're going to be doing is it's going to complement the Warfighter training team. However, if you're on a different training team, you can still do this add-on program. But it's going to be 6 days a week total. 5 days a week are going to be like, I'm going to call it more dynamic mobility type stuff. 3 exercises. It'll take you about 10 to 15 minutes. You can do it as a warm-up. You can do it as a cool-down. You can do it as an extra session in the evening. And then your 6th day is going to be a recovery day. That'll be the end of the week session. That one will be a little bit longer, and that one's going to be more down regulation focused. So that one you will be doing kind of like some stretching, soft tissue stuff to try to come down after the week, get ready for your rest day, prepare for the next week. So 6 days a week, we're going to hit heavy hitters are going to be hips, spine, and shoulders. We're also going to add some neck and upper back work, and then we're going to add some foot and ankle work as well. So looking forward to it. I think it'll be super beneficial to you guys as like a bolt-on program. Again, you can do the sessions however you want. They kind of work different for everybody. If you do a warm-up, cool down, separate session, it's all good.
No, it's awesome. And then I think one of the big things is like a lot of people struggle on like we know the importance of mobility, the mobility work that needs to go into it, but like how do you place it in there? Like
And like
during the
programming
class?
it, yeah.
Yeah, and it can get tough. I know like I'm personally a fan of putting a lot of filler work in prehab, so I'll tend to call filler work like into some of my main exercises and using that during my rest interval. But yeah, I think this is absolutely awesome to where it'll take the guesswork out away from people. And like she said, this isn't a standalone program. This is to complement the training team you're already on. So you're not buying this team and this is the only thing you are doing.
No.
And then Jamie, what is the release date for your team?
We will go live for August. Monday the 4th.
Okay, yeah, awesome. So make sure you guys are on the lookout for that. If you do not want to wait until 4 August to go ahead and start some of these awesome movements from Jamie, I've added a link in our description box for her standalone program, which is Warfighter Stability and Mobility. So you can go ahead and download that one-time download and then hop on the team when August 4th rolls around. Make sure to let us know in the comments what questions you guys have about injuries or anything you'd like to see us discuss in the future. Thanks for being with us this week.